So we'll start with Dr. Noopur. Dr. Noopur is Assistant Professor in Corneal and Refractive Surgery Services at RP Center, AIMS. And she will be covering the management of corneal infections. Mic is on? Yeah.
Coming to this course, and we would be now reviewing some of the newer evidence and, of course, the established evidence in management of corneal infections. The talk would be involving all types of keratitis and then summarizing the challenges and way forward. Viral keratitis, as we all know, can be caused due to herpes simplex virus or the herpes zoster adenovirus or cytomegalovirus and other multitude of viruses which are upcoming. And so the most common keratitis that we encounter is the herpes simplex keratitis, which is the most common, and the diagnosis usually is clinical in our day-to-day clinical practice. But if we have atypical presentations and if the patient is not responding, we may go ahead with doing a polymerase chain reaction or an immunofluorescence or a viral culture as part of some trials, or also as in the clinical setup if and when needed. In these cases, the compliance and follow-up is the most important thing. If the patient is compliant and complies to the treatment, usually we are able to manage the recurrences. But if the recurrences keep on happening, it hampers the quality of life. Then we need to look for precipitating factors. And the main management pearls for herpetic eye disease is basically guided by the two trials, which were the HEADS 1 and the HEADS 2 study. Which the clinical implications of which were involved two trials. So the clinical implications were both on all morphological types of herpetic eye disease. The epithelial disease, they said that only topical acyclovir is good enough. For stromal disease, topical steroids. For endothelial disease, oral acyclovir and topical steroids together will lead to better outcomes. And for prophylactic uses, you will need to add oral acyclovir twice a day for an year, because that was the time duration of the trial. However, after the HEADS trial, there have been other trials which say that even topical jancyclovir is good enough to treat epithelial disease. For stromal disease, oral acyclovir has a role, though HEADS study said there was no role because there could be some presentations wherein we have a stromal disease, but it is actually shadowed or not being picked up. The endothelial disease is not picked up in there may not be a purely stromal presentation involvement by the virus. And in the prophylactic cases, you can for herpetic eye disease, you can use oral valcyclovir 500 mg OD also. So just to go over a few cases, which some with typical presentation, some with atypical presentation. This is a case of an hepatic epithelial keratitis, which shows a characteristic pattern of the dendritic ulcer, and with the bulbous ends, the fluorescein has stained. So for this patient, a topical acyclovir ointment, 3% 5 times a day, is the standard treatment. You have to give prophylactic antibiotics and cycloplegics with lubricants. However, if you treat this patient with topical steroids, you will get this presentation, which is a geographical ulcer. Now the dendrites have coalesced to form of epithelial defect, which is a geographical ulcer. So topical steroids should not be used in case of an epithelial keratitis. If you have a stromal involvement with the epithelial keratitis, please first treat it with the topical acyclovir or a topical antiviral. Add on steroids later when the epithelial disease has taken, because it leads to more activation of the virus at that site. This is another case, a 33-year-old gentleman who had undergone penetrating keratoplasty for healed keratitis, which was probably viral in nature. You see a recurrence even after 2 days of the surgery, which and you could see the descemet folds, the pigments appearing, the increased corneal thickness, which responded to oral acyclovir 5 times a day, topical acyclovir ointment, a prophylactic antibiotic, and cycloplegic with lubricants. Topical steroids were withheld till the ulcer healed, but we could add on oral steroids for systemic immunosuppression in such cases. This is another case with a different presentation. There is a stromal melt with a very large dendrite, which was treated the same way, and an oral acyclovir helped in this case. Another atypical presentation of a recurrent viral keratitis in this patient post penetrating graft, wherein we had a melting of the graft host junction with differential thinning, and the other eye showed a vascularized corneal opacity, so the patient had bilateral keratitis. The stromal component of a hepatic eye disease is actually treated with a topical corticosteroid and topical cycloplegic with full dose of acyclovir, oral acyclovir, which is continued twice a day for an year or beyond, depending on how the patient responds and depending on the recurrences that he develops after the first incident. This is another case where you can see the Wesley's immune ring in this patient. Treated the same way, you have a differential thinning of the stromal involvement and the endothelial involvement, so you have to give oral acyclovir along with topical steroids and cycloplegics. This is a case which was talking about where you have a mix, where you have both the epithelial involvement and the stromal involvement. In such cases, you have to treat the epithelial involvement with the topical acyclovir, withhold topical steroids, and you can give oral acyclovir and oral steroids if needed. But the oral acyclovir can affect, and when you have the ulcer is healed, then you can start the topical steroids for faster resolution of symptoms and signs. Another case of marginal viral keratitis with an epithelial defect, stromal lysis, and stromal infiltrates, which again responds to oral acyclovir and copious lubricants, withdrawal of any epitheliotoxic drugs, and steroids have to be started later. So the next presentation, which is fulminating and where you have an active viral replication, is the necrotizing viral keratitis, which needs to, though you will have to manage surgically, but before that, institution of full oral dose of acyclovir is important, along with cycloplegics and topical steroids. Here, anti-glaucoma therapy and then a tectonic PK, or if you have a smaller perforation, a glue BCL, or even you can graft it with an optical grade tissue so that they have better outcomes. But the full dose of oral acyclovir during the preoperative and the perioperative period is important for better outcomes. So this is another manifestation of a pure endothelial disease with a disciform viral endothelitis with focal corneal edema. Another case with a linear involvement with linear endothelitis with pigments and Descemet's fold. And you can have a bilateral diffuse endothelitis with increase in the corneal thickness, and the trabeculitis and the iridocyclitis associated with the viral disease need to be treated. So anti-glaucoma therapy is an important constituent of this regimen. Another case where you have the Descemet's folds, there is no epithelial defect, but only the stromal and endothelial. So here, oral acyclovir with topical steroids is a mainstay of treatment. So in all these cases of stromal and endothelial disease, oral acyclovir for 14 days and then for prophylactic days for another year or more, topical steroids with adjunct therapy of topical antibiotic, topical cycloplegics, lubricants, and anti-glaucoma therapy is important for treatment of such cases. Another manifestation of hepatic eye disease or a long-standing sequelae, you can have neurotrophic keratitis. Here you need to withdraw all the epitheliotoxic drugs and give more of oral drugs, and you have to give copious lubrication, non-preserved lubricant drops, or you can give autologous serum, platelet-rich plasma. You can have nerve growth factors like senegenum, oral vitamin C, doxycycline, depending on what case. If the ulcer does not respond to maximal medical therapy, then we may have to do an amniotic membrane graft or a tarsorrhaphy in such cases. So coming on to herpes zoster keratitis, here you can see the diagnosis is purely clinical. You have the involvement of the trigeminal nerve of the vesicles on the skin, and if the tip of the nose is involved, you would usually see the involvement of the cornea. So here you have a case with corneal stromal lysis, some pigments, and also some vascularization. So this is treated with oral valacyclovir, 1 gram thrice a day for a week, or oral acyclovir 800 milligrams 5 times a day, along with topical therapy, including topical acyclovir, prophylactic antibiotics, cycloplegic, and lubricants. Steroids again are withheld till the epithelial defect heals. Another case, just to show the difference between the dendritic ulcer, it does not have this epithelial keratitis of zoster, does not have the typical dendritic pattern of a herpes simplex virus, and the terminal bulbs are also missing. Another case of a keratouveitis with herpes zoster. And this is an elderly gentleman where you see a perforation. So this has to be, with the medical management, we have to do a tectonic keratoplasty along with. So this is all guided by the zoster eye disease study, which is still ongoing, and it is actually studying the role of prolonged suppressive valacyclovir treatment, 1,000 milligrams orally for an year, whether it reduces the ocular complications and the postherpetic neuralgia. So this is another child with a varicella zoster infection. The typical skin lesions were seen, and she was then treated with a tectonic keratoplasty and full dose oral acyclovir according to her weight and age. Coming on to adenoviral conjunctivitis, it presents, as we all know, it's the most common conjunctivitis, but it may have a corneal involvement in forms of subepithelial immune infiltrates. The guide to treatment is that we need to manage it properly. Basically, the diagnosis is clinical, but in atypical presentations, when we need to know strain in epidemic keratoconjunctivitis, or in case of a recurrent disease, there is no response, we may go ahead with some tests which are rapid immunofluorescence tests or viral culture. There is a rapid adeno detector available for such cases. Such a case can be treated with a copious amount of preservative-free lubricants. It is known that the stabilized oxychloro complex with the oxychloro ion has antiviral properties, and it helps in faster resolution of symptoms. But if you have subimmune infiltrates which are active and involve the visual axis, you may need to give steroids, but the steroids are known to increase the recurrences. So the other options are you can give povidone iodine with steroid, which have been shown in trials to have lower recurrence rate. The other alternatives are topical cyclosporin, cidofovir, and ganciclovir. So the important things in management for any adenoviral conjunctivitis is a prompt management, the treatment of dry eye, increasing the local and systemic immunity. So dry eye needs to be managed, and the judicious use of topical steroids, and they may have a hypermetropic shift, so you may need to give them newer refractive corrections in such cases. This is a typical clinical presentation of a cytomegalovirus keratitis, which shows coin-shaped keratic crespi, sometimes which are linear, and you do have a corneal edema with them. Though the consensus on the management of CMV endothelitis is not there, but the further trials were done, and it showed that ganciclovir gel and systemic antiviral therapy, along with topical steroids, do have a role. However, using only topical corticosteroids is a risk for increasing the recurrence in such cases. So a word about COVID keratitis. There have been some reports where ganciclovir ophthalmic gel has been shown to be effective. And we did have a case of bilateral keratolitis following COVID vector vaccine, recombinant viral vector vaccine, and which was managed by a tectonic keratoplasty. So coming on to bacterial keratitis, we all know it is to be treated with a combination of fortified antibiotics depending on culture sensitivity, given 1 hourly, then 2 hourly, depending on response. You have to supplement it with the topical cycloplegics, anti-glaucoma drugs, and topical corticosteroids. By the trials have shown that you can start after the ulcer shows a response after 48 hours of starting antibiotics, but still the decision is on the hands of the treating physician, and the results are equivocal. Systemic antibiotics are indicated in cases of a large ulcer, ulcers with scleral involvement, with endophthalmitis, which are perforated, when you are dealing with patients who are either children or elderly, and in patients who have had a corneal graft. So this is just to show the response of a fortified antibiotic, which leads, this was a 67-year-old diabetic, but with controlled sugars and on fortified antibiotics, it healed completely to form a vascularized corneal opacity. But you may have to manage surgically some cases which shows perforation. Depending on the size of the perforation, you can do a glue BCL or a patch graft or a therapeutic keratoplasty. Cochrane reviews have shown that PAC CXL has again equivocal role, but it can be tried in patients which are refractory to management. Coming on to fungal keratitis, as we all know, that it depends on the organism. The most common organisms being filamentous fungi. First, natamycin is tried, and if there's a good response, then it's fine. Otherwise, you can add voriconazole. There is a TST protocol, so depending on the response, you may go in for a or addition of an oral antifungal, or you may eventually go in for a therapeutic keratoplasty. So this case is like fungal keratoplasty, you need to debride it. That is one. If there's a plaque formation on the epithelial surface, give natamycin and prophylactic antibiotic with cycloplegics and anti-glaucoma medication. The oral antifungals may be added in the severe ulcers and with scleral involvement. So this is a very small ulcer caused by an alternaria species which responded to just topical natamycin and homatropin. So the decision to treat a fungal ulcer is also guided by a MUT trial, which was MUT1 and MUT2. MUT1 was voriconazole versus natamycin, and MUT2 was addition of oral voriconazole. However, the point to note is that it is for Fusarium species, and it was shown in this trial that natamycin was better to treat voriconazole, but this is for Fusarium species. Shall I go on? So, and the addition of oral voriconazole was only there was no difference in the rate of corneal perforation. So, but there was another study to show that topical voriconazole can be useful adjunct to natamycin fungal keratitis. Just the difference here was the cases were aspergillus, whereas in the MUT trial, the maximum amount of cases were Fusarium. So this is a typical case of fungal keratitis with an endothelial involvement and a plaque with endothelial involvement. So a therapeutic keratoplasty was done for a non-helial cornea which did not respond to maximal medical therapy. Just to complete the picture, the acanthamoeba keratitis is then the standard of treatment is initially giving hourly round-the-clock PHMB or chlorhexidine or propanidine, but this should be at least continued for 3 months following treatment, or maybe 6 months, because the cysts do not go away and the trophozoites may remain. And the surgical treatment is sometimes because they are refractory to medical treatment if not treated early on. So penetrating or a therapeutic DALC may be needed in these cases. So in all this, what we gain is that the upcoming challenges to treating microbial keratitis is an antimicrobial resistance. We do not have a point of care diagnosis, meaning that if you do not have a microbiological setup at the point, because we all know that infectious keratitis occurs at the rural level, and in the primary eye care level, you do not have a microbiological setup. So having a diagnosis at that point of time and care is important. So the primary eye care level has to be strengthened so that there's an early referral and networking, and prevention is definitely the key for such cases. Thank you.